You're muted.
Good evening to one and all. Am I audible now?
Yes, perfect.
Wonderful, wonderful. So today I would like to welcome all of you for a session which will be conducted by Dr. Jewell Joseph. He is a radiation oncologist by training and profession, but he takes special interest in palliative medicine. Currently, he is working as an assistant professor in CMC Vellore. He is a faculty for the prestigious IMPACT program conducted by National Cancer Grid. IMPACT is an integrated module for palliative care, specifically for oncologists working in the field of head and neck cancers. He completed his MD radiotherapy from Government Medical College, Thrissur. Currently, as I told you, he's in CMC Vellore. And over to you, sir. A very warm welcome to you. Looking forward to your session for the evening.
Thank you, Dr. Deepak. Thank you, Palliative India, for giving me an opportunity to have a discussion with you all. Am I audible?
Yes, sir, you're audible.
Okay, I'll just share my screen.
Sure.
Okay, I hope the slides are visible. So without further delay, we'll start. Today's topic is emergencies in palliative care. The name itself might sound as an irony to at least some of you, because emergency in quotes is not something that we usually associate with palliative care. Palliative care is usually seen as a very calm, sedate kind of experience, and not like the firefighting kind of emergencies that we are used to in the other fields of medicine. But believe me when I say that we experience quite a lot of emergencies in palliative care. So today we'll just discuss about very few. So what is an emergency? So basically, in the context of this discussion, we can define emergency as any medical condition which poses a threat to either the life or quality of life of the patients if we do not do an immediate intervention. So this is something that we can some kind of a definition that we can give for emergencies. So the question is, what are the emergencies that we usually face in palliative care? See, as of any other patients, any emergency can happen to anybody, whether it is in palliative care or any other specialty of medicine, right? From a myocardial infarction or an epilepsy or all sorts of things. But today I'm actually trying to just point out a few things that we routinely face in palliative care. And again, all these things are topics on themselves, so we may not get enough time to cover everything in detail. But please please see this as just an overview or a bird's eye view of certain scenarios that we usually face in palliative care. And of course, during the part of this module, you will get detailed explanation on each of these topics each of these topics separately. So before we face an emergency, or whenever we see an emergency in palliative care, so there are always few things that we consider. So even before starting an emergency, when we see a patient in palliative care, the early identification of risk is actually very important. So this actually happens before the occurrence of the emergency itself. Is there a risk? So for example, if there is a patient with a head and neck tumor, so a huge tumor, which is actually infiltrating the carotid vessel, so we can expect a carotid blowout, or a patient who is having multiple spine metastasis, impending cord compression. So we expect that patient to have a spinal cord compression in the future, in the course of the disease. So this the risk identification actually starts even before the occurrence of the emergency itself. Once that emergency happens, or once the patient presents to us with an emergency, the first question that we usually ask is that condition reversible? So if it's not reversible, or if there is nothing that we can do about that particular problem, particular problem, so there is no point in going through with unnecessary investigations and causing more distress to the patient. The first question that we should ask is whether it is reversible. Second thing is, even though if it is reversible, is there a meaningful benefit? So for example, a patient who is in his end of life, completely bedridden, and towards the end of life, and you find that there is a new onset weakness of his left lower limb. So the patient is actually very drowsy, or not conscious nearing the end of life. So even if you find that there is a sudden, on your clinical examination, you find that the patient is not moving this or her right or left, whichever leg. So if you are not going to gain anything, even if you find out the cause and treat that particular cause. But if the same situation happens in a patient who has a malignancy and who is doing well and who is in the early stage of his cancer treatment, that actually changes the game. So the second question that we usually ask is, even if we find an emergency, even if it is reversible, is there a meaningful benefit that we can offer by treating that or by intervening? So third thing is the most important, what does the patient family want? So as palliative care physicians, we usually take pride in the fact that we are patient advocates. So we always, as everyone should be, I'm not telling that the others are not, but again, this is something, especially in palliative care, that we put a lot of stress on, is that the wishes of the patient and the family should be paramount and we should be respected. So these are the things that we should consider before we go about investigating or treating any of these upcoming emergencies. So these things, which are emergencies I'm talking about in this presentation, so these things remain constant. So these are the guiding principles that allow us to help the patient with a particular emergency. So as I mentioned, there is a lot of emergencies that can happen to any other patients. Same is the case with palliative care. So what I'm trying to do here is I'm just pointing out a very few things that we actually come across routinely in our practice, just to give you an overview. So we can just basically classify it according to the systems. Neurological examples could be spinal cord compression, increased intracranial tension and delirium. Respiratory system would be airway obstruction, acute or subacute. Coming to vascular, an SVC obstruction, superior venal cavity obstruction, or a hemorrhage. Metabolic causes we usually encounter are hypercalcemia and hyponatremia. Skeletal system will be pathological fractures, pain, and especially we deal with a lot of pain crisis and opioid overdose in very rare situations. These are the things that we encounter. So again, I'm not going to talk about each of these things in detail, but we'll just discuss briefly about some of these things. So we'll just start with the neurological symptoms. First one would be malignant spinal cord compression. So malignant spinal cord compression occurs in about 3 to 5% of all cancers. The most common tumors which are responsible for spinal cord compression are solid tumors, example prostate, lung, and breast. So these are the tumors in which bone metastasis is the most common. So these are the most common cause of spinal cord compression as well, obviously. Hematological malignancies, example would be multiple myeloma, lymphoma, etc. Myeloma especially affects the bone with a lot of lytic lesions, and there can be some compression fractures which is leading to a spinal cord compression. Lymphomas again can cause some epidural masses, and which can again result in spinal cord compression. Most common site of spinal cord compression would be thoracic spine. Spinal cord compression can lead to pain, mechanical instability of spine, and in the course of the disease to neurological deficit as well. So coming to the pathophysiology, so these basically is the various stages through which is epidural soft tissue mass actually causes a spinal cord compression. Here you can see the surrounding thing would be the bone. This will be the canal around the spinal cord, and this will be the cord itself. This will be the thecal sac, and this will be the yellow color one will be the cord itself. See here the tumor is in the bone, which is actually just touching the thecal sac without causing any indentation. When it grows, it actually compresses the thecal sac, but it does not touch the spinal cord even now. So as the tumor progresses, it goes into the thecal sac and actually touches the spinal cord. And here you can see the spinal cord compression happens in the fourth figure. So what happens is once the tumor enters the thecal sac, it actually grows through the pathway of least resistance, which would be the thecal sac itself. So rather than just penetrating here and going there, so it actually grows circumferentially, which will be the pathway of least resistance. So what happens is it will actually grow circumferentially, and if left untreated, it can actually cover the entire spinal cord and cause compression. So what happens is initially there will be compression, And once the tumor grows around the spinal cord and cover the thecal sac, there would be some venous stasis. There will be some stasis of the blood. So what happens is once the venous stasis happens, there is some vasogenic edema. And once the venous stasis happens, obviously there will be some inflammations. Interleukins and prostaglandins will also be secreted, which will again contribute to the development of edema. So once this vasogenic edema is left untreated and if it progresses, it eventually leads to ischemia, which again, if untreated, will lead to infarction of the spinal cord and permanent neurological damage. So this will be the natural history of a tumor, which has actually metastasized to the vertebra and eventually goes to the stage where it causes spinal cord compression. So the signs and symptoms, the most common symptom of impending spinal cord compression would be back pain. The important thing to note here is that it occurs in about 95% of the patients, and it happens actually weeks before the actual cord compression occurs. So whenever a patient, especially with a malignancy with a high chance of bone metastasis, complains first about back pain, you should be very careful because this is something that is very common in spinal cord compression, and because it happens weeks before neurological deficit, this is something that we can potentially reverse. So once it actually grows, it can affect some nerve roots and it can cause radicular pain, which can happen in around 40% of the patients. So as the tumor progresses, it can result in neurological symptoms, autonomic symptoms like bowel and bladder dysfunctions, some hemodynamic instabilities, etc. So in our clinical examination, we can usually elicit some spine tenderness if there is a bone met, and we can obviously see for some neurological and autonomic signs. Neurological signs would be any motor weakness, sensory weakness, exaggerated reflexes, etc. Autonomic signs would be any loss of bowel tone and all those. So coming to the diagnosis, the gold standard for diagnosing spinal cord compression would be MRI, because we'll be able to see clearly about the bone, and also if there is any soft tissue components which are causing the spinal cord compression. X-ray can also be seen. The problem with X-ray is if there is no obvious fracture or something, we cannot probably identify the lesion in X-ray, and the sensitivity and specificity is very low. One important thing that I want to stress here is that if you suspect a bone met, a vertebral met to a particular region, and if you are going for an imaging for that particular region, it is always helpful. It's always beneficial to screen the entire spine rather than focusing on an area itself, whether it is X-ray or MRI. So let me tell you an example. If a patient comes to you with low back pain in the lumbar region, and you have some spine tenderness there clinically, and you suspect a bone mets, and if you are going to scan that particular area, lumbar spine itself, as we saw earlier, the most common site of vertebral metastasis would be the thoracic spine. So there is a good chance that there may be another metastasis in the thoracic spine. It may not be the case always, but it is always beneficial to screen the entire spine if you are going to image a particular region for bone mets based on clinical suspicion. So coming to the treatment, so first thing would be to advise bed rest to not to aggravate these things. Second thing would be to correct the pain. Most common things used would be opioids and adjuvants. So I hope that the opioids session is already over for you. And opioids usually is given for nociceptive pain and not neuropathic pain. Is nociceptive, neuropathic, all those things are already covered?
Yes.
Yeah, it's already covered, right?
Yes, sir.
Yeah, okay. So opioids usually is given for nociceptive pain, but it is said that for 30% of the neuropathic pain, opioid is also beneficial. 30% of neuropathic pain responds to opioids as well. And obviously, since nerves are involved, nervous system is involved, adjuvants may be beneficial. The question is to give and whether to give NSAIDs, non-steroidal anti-inflammatory drugs. So as we saw in the pathophysiology, there is prostaglandin secretion in that particular region, and there is always some inflammation. So the question of giving NSAIDs is really relevant. Logically thinking, there may be a reason. So we'll just hold on to that question and then address it a few slides later. So if there is some bowel and bladder problems, if there is some incontinence of urine or stools, we can use some laxatives, and laxatives may not be beneficial sometimes because there may not be any tone there. So digital rectal evacuation may be required, and catheterization for urinary incontinence. So coming to the treatment of the cause in the sense the tumor itself or whatever is causing that compression. So the steps would be steroids, surgery, radiotherapy, and chemotherapy. We'll come to that from each of them in detail. So steroids mainly, see, one of the important things that we see for steroids in palliative care, just remember this word, peritumor edema. So wherever there is peritumor edema, if whether it is in the gastrointestinal tract or the central nervous system, wherever it is, so steroids will be definitely beneficial. So whenever there is tumor, there is some surrounding inflammation and there is definitely some edema. So definitely steroids is beneficial. It has an anti-inflammatory effect and anti-tumor effects itself, especially if it is something like a hematological malignancy, like a lymphoma. It has a specific anti-tumor effects itself. So it will reduce the edema and it will reduce the compression of the spinal cord. So the doses would be as high as 16 to 24 milligram per day. And we will start the steroids and we will initiate some definitive treatment. And once the definitive treatment is initiated, we can actually try tapering it off. So that is about steroids. So important thing about steroids is that once we give steroids, it is always important to give gastroprotection. And here is the problem with NSAIDs. So although NSAIDs can have a role, since we are giving steroids, concurrent use of NSAIDs can cause an increased risk of gastrointestinal bleeding. So if you are giving steroids, it is always advisable to avoid NSAIDs because one thing, steroids will take care of the inflammation by itself, and the concurrent use of NSAIDs can cause increased risk of gastrointestinal bleeding. So, and gastroprotection is very important when giving steroids. So other treatment option would be radiotherapy, surgery, and chemotherapy. So radiotherapy would be essentially palliative radiotherapy with usually either 20 grain 5 fractions or 30 grain 5 fractions or 30 grain 10 fractions or after. So there are studies for giving increased dose also based on the disease status and the type of the disease. So radiotherapy will actually control the tumor and actually it can actually reduce the neurological weaknesses if presented early. So it is always important to give continuous steroids along with radiotherapy because initially radiotherapy can cause some increase in inflammation before it actually causes the regression of the tumor. So it is important to continue steroids along with chemotherapy. Surgery is basically for the stabilization. So if there is a fracture and if the patient is having very good GC, general condition, and the patient is having a very good response to chemotherapy or a favorable tumor like a prostate cancer, and if we expect a long survival, relatively long survival, it is always we can always consider surgery for stabilizing the spine to prevent further damage, so that the quality of life of the patient will also be improved. Chemotherapy will be usually adjuvant after radiotherapy, especially if the disease is responding to chemotherapy, and early initiation of chemotherapy in hematological malignancies like lymphoma can be really beneficial in this situation. So this is about the treatment for spinal cord compression. Prognosis, the most important thing to consider is that the most important prognostic factor is the pre-treatment ambulatory status. So if the patient is not ambulatory prior to treatment, and the second thing would be the time of initiation of treatment from the onset of motor deficits. So if the patient is not ambulatory or if the patient has an established motor deficit prior to initiation of the treatment, and the time gap usually says 48 hours. If 48 hours have passed after the development of neurological deficit and the treatment initiation, we say that it is very unlikely that the patient will get back the function that he previously had. So important thing is identifying early and initiating whatever treatment we are doing as early as possible. Very important, especially in spinal cord compression. So moving on to increased intracranial tension. So it can usually happen with metastasis to brain and meninges or a primary brain tumor. So metastasis to brain would be more common than primary brain tumor. It is always said that the most common tumor of brain would be brain metastasis and not primary brain tumor itself. So it is more common. Most common cancers to metastasis to brain are lung, breast, melanoma, etc. Symptoms would be as in any increase in ICT. Not, you must all have come across increased ICT, even in non-malignant situations. So headache, vomiting, seizures, altered sensorium, etc. he typically described vomiting as projectile vomiting in increased intracranial tension, which is not preceded by nausea. But that is not may not be always the case. Sometimes they can have nausea also, but a projectile vomiting is highly suggestive of an increased intracranial tension. So treatment is very similar to that of spinal cord compression. Steroids in the same dose, initially 60 to 24 milligram, followed by tapering dose. Osmotic diuretics like mannitol has been traditionally used, but the effect is questionable, but still the books recommend and we are still using. Surgery, especially for a single brain met. So that is surgery is not an option if there is widespread metastasis in the brain and there is a very huge mass defect, etc. Surgery can be considered if there is very limited or a single brain metastasis. Radiotherapy can either be a stereotactic radiosurgery or a very concentrated kind of radiotherapy to a single bone metastasis. So what happens here is the bone metastasis will be single or a very limited in number, and we'll be giving a high dose of radiation to that particular metastasis alone. And it can be whole brain RT also, where the entire cranium is irradiated. Where there are multiple meds, seeding of meds all over the brain, etc. Then whole brain RT, whole brain radiotherapy would be the treatment of choice. Chemotherapy and targeted therapy can also be considered. So I just wanted to mention that even in targeted therapy, in adenocarcinoma lung, where there is immune markers are positive, there are newer agents which can penetrate. The problem with chemotherapy, usually with brain mets, is most of the chemotherapeutic agents does not cross the blood-brain barrier. So even for tumors, if we are giving chemotherapy and if we see that the tumor everywhere will be responding very well to chemotherapy, suddenly one day the patient can develop brain mets. That is the problem with chemotherapy. Most of the drugs does not cross the blood-brain barrier. But with the advent of new targeted therapies, there are targeted therapy agents, especially in lung cancer, which can actually cause cross the blood-brain barrier and can cause decrease in brain mets. So if you identify a brain mets and if that is not causing neurological symptoms like increased intracranial tension, there are options to withhold whole brain RT and then continue with systemic therapy alone. That is also possible. But once an increased intracranial tension and symptoms develop, but definitely RT or steroids or something would be definitely needed. So analgesics, coming to analgesics, so they can have some pain, but mostly due to this disease itself, so which can be reduced by steroids and other measures. If you are using analgesics, ideal would be paracetamol and NSAIDs. The problem with opioids is theoretically opioids can cause increased intracranial tension, especially tramadol, which can also reduce the seizure threshold. So such cases we usually avoid opioids. Better to go with paracetamol and NSAIDs. Adjuvants definitely as required. So again in adjuvants, it is better not to use antidepressants because they have a theoretical possibility of increasing the seizure threshold. So anti-seizure medications like pregabalin or anything else would be more beneficial here. So that would be the treatment regarding increased intracranial tension. We'll go to the respiratory system. The most important thing would be an airway obstruction. So it can actually, it can be an intrinsic tumor or anything else which causes that airway obstruction. I'm not talking about benign causes of airway obstruction here. It can be an intraluminal tumor or an extrinsic tumor by a tumor, extrinsic compression by a tumor or a lymph nodal mass in the mediastinum. So airway obstruction can present as acute and subacute. So subacute airway obstruction, we'll have some time. So the patient usually presents with shortness of breath and stridor. Stridor would be noisy breathing. So classically, we associate inspiratory stridor to be associated with the larger airways and expiratory sounds like wheeze, which is associated with the smaller airways. So inspiratory stridor is highly suggestive of a impending larger airway obstruction. So the management would be again oxygen. Steroids will come, all these things. So wherever there is obstruction or edema, steroids will come. The idea would be it will reduce the peritumor edema, the inflammation within the tumor, and it can actually relieve the obstruction to some extent. Again, opioids and benzodiazepines. If the patient is actually very breathless or in distress, opioids can definitely result in decreased work of breathing, and the patient can be calmed down and relax a little. So benzodiazepines also, if the breathing difficulty is associated with some anxiety, benzodiazepines will definitely help. Radiotherapy is another option. The same way radiotherapy works in spinal cord compression and brain mets. The local radiation to that particular tumor can cause shrinkage in tumor and relieving of obstruction. The question of tracheostomy is usually something that we encounter very frequently. if it is in the upper airway, especially with head and neck tumors, whether to go for tracheostomy or not is an important question. So tracheostomy is not advisable for all patients, especially patients in the end of life. And that has to be a multidisciplinary discussion and a discussion with the family before we go for tracheostomy. Obviously, it is not possible in lower airway obstruction, at least in the upper airway obstruction. This will be the management. The dose of steroids will be again similar to that we give in malignant spinal cord compression and increased intracranial tension. So acute airway obstruction would be very difficult to treat. It can actually have severe progressing dyspnea and hemodynamically collapse. So the management here would be essentially to calm down the patient, sedate the patient, and to educate the family, support them, and just be with the patient. So the distress can be managed by sedation, or even family can be supported. So this is something that we, this is a condition that we actually cannot alter the disease process itself. We can actually provide supportive care and family support in this situation. So we are just coming into the vascular thing. Another important thing would be superior vena cava obstruction. So it is quite common, especially in the right-sided apical lung tumors or any mediastinal mass or all sorts of things. So the typical signs of SVC obstruction would be edema above the chest, facial edema, arm edema, etc. You can see here a diagram where there is definitely puffiness of the eyes, facial edema. There can be brain edema as well, which can cause headache and all those things. There can be retinal edema, conjunctival edema, facial puffiness, dilated veins over the chest. One important clinical sign that we can appreciate here if we look closely is there will be elevated JVP which is pulseless. It is a classical viva question that we have been asked from our MBBS base. Pulseless JVP is a sign of superior vena cava obstruction. That is one thing that we can appreciate here. There will be dilated veins over the chest itself. The patient will be breathless, etc. Usually seen with bronchogenic carcinoma, lymphoma, mediastinal germ cell tumor, etc. Treatment again. See, wherever there is compression, there will be steroids. Again, steroids, the same dose as we mentioned earlier for the other conditions. Radiotherapy and chemotherapy is an important thing. Again, radiotherapy, local radiotherapy or chemotherapy. See, the one thing I just wanted to mention here is that just because a patient has a superior vena cava obstruction, the treatment of that particular disease is not essentially palliative. So that will actually depend on the stage. So just because the patient has an SVC obstruction doesn't mean that he is due for palliative treatment. So we can actually treat radically if the disease is within a limited stage. Radiotherapy and chemotherapy. Chemotherapy will be definitely beneficial for lymphoma, mediastinal, germ cell tumors, etc., where they are really chemosensitive. Radiotherapy definitely can be considered for all conditions. Diuretics and bronchodilators are something that we have been traditionally giving. Again, the benefits are questionable. Diuretics, the idea would be to reduce the fluid overload, so thereby reduce the fluid in the body, thereby reducing the venous return and reducing the congestion. But the role is questionable. Bronchodilators can also be given. Again, how much benefit it provides is a matter of question. But these things are routinely given. But steroids, as of medicines are concerned, steroids is the mainstay of treatment. One important thing we usually say as part of this would be no intravenous injections to the upper limbs, so that it won't aggravate the already existing congestion. So all the medication should be given through the lower limbs in SVC obstruction. Next, vascular complication that we usually encounter as hemorrhage. So it can be of due to many reasons. First would be tumor infiltration of the blood vessels. So thereby the tumor can actually eat away the blood vessel wall and there can be blowout of the blood vessel. Second thing would be if the tumor infiltrates the marrow, it can cause some thrombocytopenia and it can cause some bleeding. Thrombocytopenia can also be a complication of treatment, whether chemotherapy or radiotherapy to a large radiotherapy to pelvis or something like that. So that can also happen. So it can be minor or major. Hemorrhage can be minor or major. Minor bleeds, the management would be to give general measures like transfusions, vitamin K and FFP according to the stage and general condition of the patient. For bleeding control, one important thing that we can try is hemostatic RT. So initially we'll give something like tranexamic acid to control the bleeding. And once that medications are given, the next step would be to give hemostatic RT radiation or palliative radiation is very effective in controlling the bleeding in various sites. And if there is some site-specific complication like radiation proctitis where there can be bleeding from the rectum, other measures like argon plasma coagulation, steroid and sucralfate anemia, etc. can be given. So these are the outline of management of minor bleeds. So major bleeds is actually a really difficult medical condition. Once a tumor actually bleeds profusely, there is nothing much that we can do other than to sedate patient and see the most important. Even if we sedate patient, the site of bleeding would be a very major trauma to the caretaker. So there are people who develop even post-traumatic stress disorder after seeing such a massive bleed. So we always advise to use dark towels so that the blood will not be visible outside. And proper family support is essential because just being there is all we can do, and other than sedating the patient. So there is not much that we can do about the bleeding itself. Just make it less painful for the patient and family. So that is regarding major bleeds. So the next important thing I would like to cover would be pathological fractures. Most common in lung, breast, prostate, myeloma. So these are the cancers that usually affects bones more. Treatment would be surgical fixation. Again, that will depend on the general condition and the stage of the disease. So in a completely bedridden patient towards the end of life who develops a fracture of the femur or neck of femur, there is usually no role of surgical fixation. Bisphosphonates or denosumab can be given. We need not wait for a fracture to occur to give bisphosphonates. So as I am coming later, risk identification is an important thing in pathological fractures. So it is always better to prevent pathological fractures than treat one. So whenever there is a bone metastasis, especially in long weight-bearing bones, it is always important to advise patients regarding avoiding weight bearing, being careful, giving bisphosphonates, giving various braces or supports for the patients. So analgesia and adjuvants again. Analgesia, usually we use opioids. NSAIDs can be really beneficial here because they are very effective in bone pain for a short period, obviously, but they can be really beneficial in bone pain. Adjuvants, yes, because it is said that in a bone mets there is always some neurological component of the pain because there can be some local sprouting of new nerve endings. There can be injury to the local nerves by the bone fragments, etc. It is always beneficial to add an adjuvant also. As I mentioned earlier, risk identification, especially in the bone metastasis, is very important. So we can actually take measures to avoid skeletal related events in patients with bone metastasis. So there is actually a risk stratification scoring for bone mets. So it's called Miral's scoring system. So it is based on the site, pain, X-ray appearance, and size of the lesion. So this is the risk for development of pathological fracture. So if the score is 7 or less, we can actually give radiotherapy and wait. Score 8, it would be our clinical judgment. So any score more than 8, prophylactic surgical stabilization is advised. It is something that we not always use, but there is a scoring system just to be aware about. So as we can see that again, weight-bearing bones would be at an increased risk of fracture, and again, lytic lesions would be an increased risk at an increased risk of fracture. So about lytic lesions, usually diseases like lung, renal cell carcinoma, etc., produces lytic lesion. Prostate usually produces sclerotic lesions, and breast can actually produce both lytic and sclerotic lesions. So the cancers which produces lytic bone metastasis are at a higher risk of developing pathological fractures. So next thing would be coming to the GI system. So malignant bowel obstruction. So malignant bowel obstruction can occur in around 3 to 5% of patients. It can actually happen right from esophagus towards rectum. Most common site would be small bowel. Most common cause of malignant bowel obstruction, interestingly, is not a bowel cancer itself. It is ovarian cancer, and followed by colon cancer, because ovarian cancer is notorious for peritoneal spread. So that may be the reason for increased incidence of bowel obstruction in ovarian cancer. In an advanced disease, it is usually a poor prognostic factor. A patient with advanced disease developing bowel obstruction means that the medial survival is only 1 to 3 weeks. So coming to the classification, it can actually be a partial obstruction or a complete obstruction. and it can be single or multiple, or these are the different types of obstruction, partial or complete, and single or multiple. It can also be intrinsic or extrinsic. So coming to the pathophysiology, so what happens here is, so if there is an obstruction, so there is a proximal distension. So whenever there is an obstruction, the body's inherent mechanism is to push harder and to pass the contents through the obstruction. So initially there will be increased peristalsis. And the second thing would be, see, it's something like that what we do when our kitchen sink is blocked. So what will we do if the kitchen sink is blocked? We'll just push it with something and then flush it with water, right? This is what the body also does. So it actually pushes harder and flush it with secretions. So whenever there is an obstruction, there will be proximal distension. The body gets notified. It will increase the peristalsis and increase the secretion. So if that obstruction is not relieved, this thing actually will go on as a vicious cycle. So whenever there is increased secretions, there will be increased bacterial growth, which results in increased gas formation. So there will be again increased distension. So at this stage, there will be pain, bloating, nausea, and vomiting. So what happens is, if that obstruction is not relieved, so there will be increased distension. And when the distension happens, what happens is there will be inflammation also. So inflammation and this distension can cause decrease in blood supply, which can eventually lead to bowel edema. Whenever there is bowel edema, the edematous bowel will be more obstructed. So this thing will again go as a vicious cycle: obstruction, distension, inflammation, and bowel edema. So finally, if that obstruction is not at all relieved, what happens is, when the bowel becomes edematous and blood supply is less, finally the bowel gets ischemic. When the bowel gets ischemic, there will be marked distension, and the peristalsis actually at this stage would be very minimal because the bowel will be almost dead. So the symptoms at this point of time would be not a colicky pain that we expect in increased peristalsis, but will be more of a diffuse pain along with abdominal distension. So what eventually happens to ischemic bowel is there will be perforation and peritonitis. There can be sepsis and multi-organ dysfunction syndrome. This is the natural history of a bowel obstruction if we are not intervened. See, the symptoms of bowel obstruction again will depend on the site of obstruction, whether it is an upper GI obstruction and lower GI obstruction. So as we can see, if there is an obstruction here, the easy way is to just vomit out the contents, right? Rather than pushing it all the way down here, it will be easier to push out the contents. So if there is, and if the obstruction is down here, it will be really difficult to take it all the way back and vomit out here. So the idea of the body's natural thought process would be to push it harder and try to get it down through the anus. Symptoms again, in proximal GI, the pain would be more in the central abdomen. Distal GI, it would be more in the lower to central abdomen because the site of obstruction is upper and lower. Vomiting, as I mentioned earlier, proximal GI would be early symptom. Vomiting is an early symptom and it will be very severe because whenever stomach fills with food, it just vomits out. Distal GI, the vomiting would be late, as we mentioned in the previous slide. So the most important sign would be constipation in distal GI. Distension is usually absent in proximal GI because whenever the stomach is full, the body just vomits it out. So there will usually be no distension. Distal GI distension is present because there is a lot of space for the fluid and other contents to accumulate. So distension will be marked in distal GI obstruction. Constipation, proximal GI obviously will be less and more pronounced in the distal GI. So investigations for malignant bowel obstruction would be the blood investigation that we can do is serum electrolytes because there can be some electrolyte imbalance, especially if there is severe vomiting. X-ray to confirm bowel obstruction, to see the air fluid levels, which you will all be familiar with. If you want to find the cause of an obstruction, the ideal investigation to do would be a CT because it has 93% sensitivity and 100% specificity. But again, that is a clinical decision according to the stage of the patient. So this is an example of a abdomen erect X-ray. So always make sure that the patient is standing erect rather than lying down supine to appreciate the air fluid levels. So non-pharmacological measures would be resting the gut. See, it is mentioned that around 1/3 of the bowel obstructions which are presenting to our medical system, about around 1/3 of the total bowel obstruction, the obstruction relieves by itself in 1/3 of the cases. So just resting the gut would be the initial thing to do. So it is not always necessary to put an NG tube, nasogastric tube. So it is only beneficial if there is an upper GI obstruction and if there is severe vomiting. So otherwise, there is no point in putting an NG tube. And NPO is also not usually necessary, especially if the patient is having an advanced disease and a surgical intervention is not possible. Sips of fluids can be given. IV or subcutaneous hydration can be considered, but they are unlikely to improve the outcome or to improve the quality of life, especially if the patient is having an advanced disease where a surgical intervention is not possible. So nasojejunal tube can be an option if you are going to suspect an upper GI obstruction previously, because if you put a nasojejunal tube before the patient goes for an complete upper GI obstruction, there will be a way to feed the patient even if the tumor grows and causes an obstruction. So NG tube, see, ideally, I mean, I am also guilty of doing it. Whenever the patient comes with bowel obstruction, whether it is upper GI or lower GI, the first thing we used to do is just to put an NG tube, NPO and IV hydration. So nasogastric tube is rarely necessary unless the patient is having an upper GI obstruction with large volume vomitus. So surgical measures would be the gold standard: resection, bypass, or stoma. There is also palliative surgical procedures like gastric venting and stents, but this would actually be dependent on the condition of the patient. The candidates for surgery would be single obstruction, good response to anti-cancer treatment, patients having a localized disease, young patients with good performance status, and benign process of obstruction. If the surgery is not possible, then we can go with the pharmacological measures. See, the one important thing to keep in mind is that even among the patient presenting with an obstruction, symptoms of obstruction in the OPD, most of them will have a partial obstruction rather than a complete obstruction. So we can actually try to facilitate bowel emptying or relieve the obstruction by steroids and prokinetics. Steroid, as I mentioned earlier, will reduce the peritumor edema, and if there is a partial obstruction, there is a chance that the obstruction is relieved as for the time being. Prokinetics is basically, they'll increase the gastric peristalsis. If given along with steroids, they can actually facilitate bowel emptying. So it is important to note that whenever you are giving prokinetics or steroids, watch for increasing signs of obstruction. Steroids, if it's not working in 3 days, there is very less chances that it will work subsequently. So it is not working in 3 or 4 days, please taper and stop the steroids. Prokinetic, again, if you are giving prokinetic and if the patient is developing increased colicky pain, please stop prokinetics, otherwise the patient can go for perforation. So if the bowel obstruction is not responding to steroids and prokinetics and if it is a complete bowel obstruction, the next logical option would be to prevent secretion so that the load of obstruction and the load of that content would be less. So to prevent secretion, we usually do anticholinergics and somatostatin analogs. Anticholinergics usually we use tyrosine butyl bromide or glycopyrrolate. So if that is not working, we can go for somatostatin analogs like octreotide. So associated symptoms like pain and vomiting should be definitely treated. Analgesia of choice, again, opioids can be considered, but not oral opioids. Oral opioids are contraindicated in bowel obstruction because it will actually can reduce the bowel movements, cause decrease in peristalsis, etc. So we usually don't give oral opioids. We can give parenteral opioids or some patch or something, and analgesics, antiemetics as required can be given either parenterally or if it is a partial obstruction or. So we'll just mention about 2 metabolic emergencies before we stop. So would be hypercalcemia and hyponatremia. Hypercalcemia is most common in lung, breast, myeloma, and lymphoma. The proposed mechanisms for hypercalcemia is increased parathormone-related peptide secretion, which can actually increase the calcium level in blood. There can be local osteolysis. If there is a bone metastasis, the local osteolysis can cause increased calcium in the blood. Excess vitamin D secretion, which is only in 1% of the cases of cancer. Clinical features would be, see, you must have all heard the mnemonic bone stones, groans, psychic bones, and we used to learn in surgery. So basically, neurologically, there can be some irritability, confusion, sedation, delirium, etc. GI would be anorexia, nausea, vomiting, constipation. Nausea and vomiting, constipation are the most common presenting symptoms of hypercalcemia. There can be renal, polyuria, and dehydration because calcium has a diabetic insipidus-like effect in kidney, so it can result in polyuria and dehydration. So management would be based on the severity. So basically, hypercalcemia is classified as mild, moderate, and severe. 10.5 to 11.9, 12 to 13.9, and more than 14. one thing to keep in mind is that whenever you are sending calcium for investigation, always measure albumin. So total calcium in the body, the measurement will take into account both bound and unbound calcium. And since 40% of the calcium in the total body is bound to albumin, albumin levels can actually vary the calcium. So if there is decreased albumin, there is a formula for corrected calcium, which you all will be aware of. So just send albumin whenever you are sending calcium. So for mild hypercalcemia, adequate hydration may be enough. Around 3 to 4 liters of fluids can be given. For moderate and severe, some other measures would be required. So the treatment can be classified into 3 headings. Increased calciuresis, basically increase the hydration. And question of diuretics, so especially loop diuretics like furosemide. So they theoretically are said to have an increased calcium excretion effect, but it is found that Lasix alone is not sufficient to reduce the calcium. But again, if there is people with cardiovascular, cardiac insufficiency, etc., we can actually give Lasix alone, especially when we are giving increased fluids. The second option would be to reduce parathormone. We can give calcitonin. And third, this is just an explanation of the pathophysiology. So increased parathormone secretion, we can give calcitonin. And to reduce bond resorption, we can give bisphosphonates or denosumab. Again, just keep in mind that bisphosphonates are not, there is some dose modification and contraindication for bisphosphonates in renal dysfunction. So we have to be careful about it. So next would be hyponatremia. This is the last thing that we'll discuss. So hyponatremia can be actually divided as hypervolemic hyponatremia, especially which happens in congestive cardiac failure and cirrhosis. So what happens here is, even though there is enough volume of blood in the body, due to vasodilation in cirrhosis and decreased cardiac function and congestive cardiac failure, so there is not enough blood leaving the carotid baroreceptors. So it will in turn increase the ADH secretion. So there will be increased free water absorption, which can result in hyponatremia. It can actually happen in advanced stage of congestive cardiac failure. So hyponatremia and congestive cardiac failure itself is a poor prognostic factor. So hypovolemic hyponatremia we usually encounter in vomiting and diarrhea because of the increased salt loss from the gut. So euvolemic hyponatremia, this is something that we usually encounter in cancer, or syndrome of inappropriate ADH secretion. So what happens here is increased ADH secretion, and there will be increased free water absorption. So how is that euvolemic? So whenever there is increased free water absorption, the atrial natriuretic peptide actually gets activated, or aldosterone is deactivated, is suppressed. So there will be increased salt secretion, salt secretion in the urine along with corresponding natriuresis. So the volume will be maintained as euvolemia. There will be increased salt excretion in the urine even though there is a hyponatremia, and the volume would be constant. There will be hyponatremia. That is SIADH. So hyponatremia diagnosis would be anything less than 135, we will say at hyponatremia. Symptoms usually starts less than 120. It can start earlier also. Less than 105, we usually say it as life-threatening hyponatremia. So symptoms would be usually anorexia, malaise, irritability, muscle cramps, confusion, seizures, coma, etc. So if there is no symptoms and if it is not less than 120, we can actually advise increased salt intake to the patients. But when the patient is symptomatic, we will have to do correction. So management of, we'll just mention about SIADS because CCF and other things will be here. So, syndrome of inappropriate ADH secretion, the most important thing would be to restrict the fluid intake because the problem itself is increased free water absorption. So fluid restriction, 3% saline, and in severe cases, there is a drug called tolvaptan, which is actually vasopressin 2 inhibitor, which can actually be beneficial in SIADs. So when we are giving correction, it is always important not to overcorrect. So the recommended correction of sodium per day would be correcting 4 to 6 milliequivalent per 24 hours. So there is a chance of, otherwise there is a chance of one-time demyelination. Hyponatremia correction, you must all be familiar with. So total body water, you will have to find the total body water, which will be weight into 0.6 because 60% of our body weight is of water. So then we'll have to find out the sodium deficit, which will be desired sodium minus measured sodium into total body weight. So because this will be per liter, right? Desired sodium and measured sodium would be per liter. So we'll have to multiply it with the total body water. So the volume of 3% saline should be given, can be calculated by sodium deficit divided by 530 because 1 liter of 3% saline will contain 513 milliequivalents of sodium. So time needed for correction would be sodium deficit divided by 0.5 milliequivalent per liter per hour. See, this is the standard formula that we can see in books. So we can just see that if we correct at the rate of 0.5 milliequivalent per liter per hour, in 24 hours it will come around 12 milliequivalents per 24 hours. That is usually not recommended. So we can go lower. The ideal correction per day would be 4 to 6 milliequivalent per liter. And it is always important to frequently recheck the sodium. And if it goes more than 4 to 6 milliequivalents, then we have to stop the correction for the day and continue correction the next day. This is the rate of infusion. So pain crisis and opioid overdose is another emergency that we usually see, but this is actually beyond the scope of this discussion. And I'm pretty sure that pain crisis and opioid overdose could have already been covered in the sessions along with opioids. So just to summarize, I just wanted you to see all these things I have mentioned is just an overview. Obviously, we have no time to discuss everything in detail. But at the end of the session, I just wanted to stress these points. Every condition that causes patient distress is an emergency. Just keep that in mind. So I have heard of talk of Dr. Robert Wycross, who is one of the pioneers in palliative care, who has given that topic in 2012 in the IAPC conference in Kolkata, I think. So he just tells in that talk that any patient who has not passed tours in 5 days is an emergency. Any patient who has not slept in a month or 3 months is an emergency. So just have that feeling of urgency that anything that causes distress and causes serious damage to the quality of life should be treated as an emergency. So always before intervening, just ask yourself, will the intervention result in a meaningful benefit? So over enthusiasm and just avoiding is both problematic. So we'll have to find a middle path and always be patient advocates. And before starting anything, just understand what the patient wants and act. Thank you. I have taken probably 10 minutes extra. I'm sorry.
Thank you so much, sir. This is as detailed and as comprehensive as it gets for a session which is 50 minutes long. So thank you so much for that excellent presentation. I would request the participants to make it interactive now by asking. I'm sure there will be questions. You can unmute yourself or start using the chat box as well. In case a question is already being asked or discussed, I would request the others to please raise your hands and we'll get back to you.
I can see a question. What about DEXA? But I didn't see the chat box during the presentation. I am not sure about the context of that question.
Yeah, it was during your presentation, sir, and I think you have answered it already.
Yeah. Okay.
As well as the question on digital rectal examination. Now you have just closed the session by saying that anyone who has not passed tools in 5 days should be considered as an emergency. So definitely digital rectal examination is a must.
Examination, digital rectal, I mean, I don't know, I'm not sure whether it is Dr. Priyanka meant evacuation or examination. Examination is a must for all patients complaining of constipation. That is some general thing we do in examination. Evacuation, especially in patients with paraplegia, neurological things, etc., because they are bedridden for a long time. Sometimes laxative may not work. Ethical issues regarding intubation respiratory emergency. See, the respiratory emergency that I mentioned here specifically would relate to obstruction. I'm not talking about respiratory emergency due to lung metastasis or something like that, because that is unlikely to come as a sudden. The thing that we actually mentioned would be related to obstruction, either an endobronchial obstruction or an extensive thing causing a bronchial compression. So in that case, obviously, we can actually tell the patient that even if we intubate, that is not going to give much benefit to the patient. And yes, in other conditions like various other lesions, lung metastasis or a primary lung tumor, when the patient is breathless, the question of intubation is really a difficult thing to address. So the only answer I would tell you is having a clear idea about goals of treatment and the disease process itself, and having an early discussion with the patient. So once it develops, actually convincing the patient's relative that intubation will be futile is going to be quite difficult. So we'll have to foresee those complications and then start those discussions early. See, encephalopathy or hyponatremic seizures, if it is, see, any reversible condition, definitely. What I was mentioning is, see, if there is something that you can correct, and if you feel that that correction would result in any meaningful benefit in quality of life, please don't hesitate. We can actually do it at any stage of life. Even if, see, hypercalcemia and all, we correct even during the end of life, because it will actually improve the patient's quality of life. So if you find a reversible cause at any stage of the illness, and if you feel that it improves the quality of life, by all means, please go with it. That's all. If the patient has signed a DNR consent, comes with respiratory distress or a large bleed. See, DNR consent actually means that we had a prior discussion and actually we have reached a consensus regarding the goals of care. That actually makes our things very easy. So we don't need to worry about convincing somebody else. Do not resuscitate. We usually take simultaneously. Do not resuscitate and do not intubate. At least in the institution, I probably think that all palliative care units does that. So there is usually no specific separate consents for DNR and DNI. We usually take DNI, DNR consent. Suggest management of hypovolemic hyponatremia. Hypovolemic hyponatremia, fluid restriction is not at all required. Not at all required. Unless it is a syndrome of inappropriate ADH secretion. After 3% NS, after 3%, I did not get what exactly you meant by after 3% NS. After means once we have reached the target sodium levels or anything else?
Well, actually, there's a patient of CA oropharynx. He was on CRT award. So he had actually, since past 3 days, he was not taking anything. And he actually suddenly turned up in the OPD with agitation and incontinence and altered behavior. So I did his electrolytes and the serum sodium was 111. So I admitted him and 3% was given to him. So after that, when I repeated the sample, it was 120 for the next day. Yeah, for the next day again, after 24 hours, I again gave 3%, and the next day it turned out to be 126. So slowly we corrected the hyponatremia from 111 to 126, and he was much better after that. But I just wanted to know, for the maintenance purpose, we can give this, it's not contraindicated in that, right? For the hypovolemic or like when the hyponatremia is because of the decrease intake, especially the radiation, after the radiation reactions per se.
Intake, right?
Hello.
If he has an NG, by all means give orally. Or IV fluids, I don't see any contraindication.
Okay, sir.
But yeah.
Fine.
Fluid restriction definitely is not needed. Definitely is not needed.
Okay. Fine.
Because it's hypovolemic, right? So you actually encourage the patient to take more isotonic fluids.
Yes.
More isotonic fluids, not like So no restriction definitely. Okay. Dr. Gregory Foray has raised his hand. Please.
Yeah. Good evening, sir. Thank you very much for the excellent presentation. So my question is, for example, if a patient towards the end of life, you've noticed that there is an electrolyte derangement. Let's say the patient has got hyponatremia, and then the patient is at home. You don't have the way of doing the test at home. So do you still have to move the patient to a hospital wherein you can do those investigations and then you have to correct. How useful will those corrections mean to the patients?
I'm so sorry, Doctor. I was not able to understand the question fully. So, Dr. Deepak, if you have understood the question, just can you just help me with that? I mean, I couldn't.
Yeah, Dr. Gregory, the same for me as well. If you could just repeat your question.
I'm so sorry.
Okay. All right. So what I was saying is a patient who are managing at home.
Okay.
You notice that the patient has got electrolyte derangement. Let's say the patient has got hyponatremia.
Yeah.
And we know you can only diagnose hyponatremia from laboratory investigations. So
Okay.
would we want to move the patients to a hospital wherein they can do those investigations, and this is towards the end of life? Maybe the patient has got 2 weeks or 3 weeks more to live. So I was just wondering whether we still have to do those investigations and we correct the correctable, or we just continue to palliate these patients.
Yeah, I got it. See, if the patient is at home, so the treatment would be, there will be two things to consider. One is what symptom benefit will the patient have. If there is some severe hyponatremia and the patient have seizures and all, it may be beneficial to correct, but again, shifting the patient back to a hospital and doing investigation would be a joint decision with the family and the patient. So what the patient was actually, what the patient's wishes were previously, and the family's thing. So the simple thing is that if you suspect hyponatremia, clinically you can ask them to give some increased salt and see. That is the easiest thing that we can do. But if it is severe hyponatremia and if the patient is throwing seizures and all, correcting may be beneficial. But again, see, if the patient is really at his end of life, and it all depends on the patient's wishes where to spend his final days, and also it has to be a discussion with the family. So I'm afraid that there is no clear-cut answer to that. So it has to be after a discussion with the family. So see, the problem is correcting thing would be our clinical judgment, but in an end-of-life care, there are other factors as well, like the family's wishes, the patient's preferences, etc. So it has to be a joint decision. Yes.
All right. Okay. Thank you very much, sir.
Thank you. Thank you.
Thank you.
Dr. Lingdo, if you could unmute yourself.
Evening, everyone. I actually don't know if this will fall in the realm of emergencies, but I currently have a patient. He's a doctor himself. He's diagnosed with CA lung, and they suspect spine mets. So this patient, when he came to us, he was referred from another hospital, onco hospital, where he had received all therapies possible, and they had sent him to us for palliation. His NRS was 10 out of 10, and he had some neuropathic pain as well. So I had started him on tablet morphine, 10 milligram, and I had also included gabapentin, 100 milligram. But after 3 days, when I asked them to review back to me, the patient has taken just 10 milligram. Thereafter, he stopped morphine, saying that he became restless at night, he can't sleep. And he stopped taking gabapentin also, saying that it makes him too weak. And so I don't really know if his NRS is 10 out of 10 and the patient is refusing to take medication. I think he's a doctor. He must be thinking that the morphine will increase his respiratory distress. So he came today again to us. I have reduced, he was willing to take 5 milligram morphine. So I reduced it to 5. And I started him on aceclofenac and started him on amitriptyline pregabalin combination. I really don't know how to deal with the situation because he's a doctor himself and he's not very willing to take the high doses of morphine that he requires.
Yeah, that I mean, I totally understand it will be a very difficult situation because for someone who already understands those drugs, it will be difficult to convince. So what we can do is we can, since he has agreed to take 5 mg morphine, so I hope that he sees some benefit with that if he takes it continuously. So in such situations, if the patient takes a drug and sees some benefit with it, so it is more easy to convince them to take a higher dose other than straight away 10 milligram. So 5 mg, I mean, 10 milligram, you are right in starting 10 milligram because he must have already taken a step 2 before, because he has been taking treatment in some things. But 5 milligram maybe an lower dose than required. But it's a good sign that he took the medicine. And once he feels some benefit with that, I think you'll be able to convince him to increase the dose. Amitriptyl again would be, if he is feeling tired with gabapentin, it's a pretty good chance that he feels tired with amitriptyl as well, because there will be some sleepiness. So one drug that we usually use here in CMC is mirtazapine. We usually start with 7.5 and go up to 15. So it's also a recommended drug for neuropathic pain, not usually first line, but as second line or third line it is recommended. It has very less sleepiness when compared to amylin. And it generally improves the mood as well. We usually have some beneficial effect in appetite also. So if he is feeling very sleepy with amitriptyline and gabapentin, this is something that you can consider, mirtazapine. But related to morphine, NSAIDs definitely is a good thing. You can definitely add that. And related to morphine, I hope that he sees some benefit with 5 milligram, and then you can convince him to take a higher.
Sir, can you just repeat the name of the drug that you use
instead of mirtazapine? Mirtazapine.
Oh, okay.
Just,
thank you so much.
Just an option. Just I don't know if it makes a huge difference, but just another option for you.
Okay, thank you.
So we have one more question on the chat box.
Yeah.
So the question is, if there is a newly diagnosed patient who is in the terminal stages and in respiratory distress in an ER, what do we do? Do we counsel them for DNI, DNR, or do we directly go for intubation? Because the time we won't have enough time to communicate these aspects. So how to go about in this situation?
I understand. See, there can be two options. So one, we can see that whether we can just make a clinical judgment whether intubation will actually help the patient. That is one thing to do. Second thing would be, definitely have a discussion. So I have seen some approaches. I mean, ideal thing would be to convince the family and to make them understand that intubation is not going to benefit. But I have seen some hospitals doing in dire, because they will initially land up in emergency medicine. They will have to intubate. They will usually intubate, and then we have repeated discussion with the family regarding de-escalation and finally the removal of support. So that is another way. Sometimes things go, but it is really difficult. But proper communication would be definitely beneficial. See, the thing is, even if you intubate, I don't know with a terminal patient with a respiratory distress how much benefit he can have. Yeah. So again, no easy answer. So definitely discussion. And if a patient comes to in a condition when if you feel that the patient will die if you don't intubate, I don't know if with the terminal stage disease with the compromised lung, how beneficial it would be to intubate itself. So I don't know if intubation would be of any benefit in such patients. So terminal in the sense, the reason he came into terminal must be his lungs must have been completely affected with the disease, or there is a complete obstruction or something like that. So that will be really difficult. See a lung patient, see if the lungs are completely gone, so even if you put a tube inside and pump oxygen, so how much benefit the patient would get is another question. In that condition, I think the best route would be to try and discuss with the family. And just tell them that intubation will not actually benefit the patient in any way. So if they put you under pressure, and if it is a dire situation, that I don't know, I mean, maybe you can intubate and then talk them, but that is not really advisable. Yeah, I understand. There's a little time. So even if you intubate, what are you expecting? What advantage are you expecting? So just for the sake of the family pressure, you want to intubate? Yeah. I mean, if it's see, the thing is, all these things, it should, especially in a condition like India, in a country like India, where doctors are beaten up for every now and then. So I would, if there is a situation where you have to see, I don't know. I mean, how many people will support me on this? If you face a situation where medical ethics is on one side and your personal safety is on the other side, I would just advise you to go with your personal safety, whatever to make yourself safe. If that is a situation, if somebody is putting you under pressure and threatening you, yeah, please do whatever to make you safe. But ideal would be if to have a discussion. See, the first thing that you can convey to the patient is that even if you intubate, relative is that even if you intubate, there is no benefit. At least that thing you should convey. Then yeah, according to see, I exactly don't know what situation it was and how severe it was. Exactly.
Yes, sir,
There is no question about that. Yeah, we all would like to follow ethics, but yeah, for me, I mean, it's not like a general opinion. I'll just advise you to go with your personal safety rather than anything else.
Thank you so much, sir, for answering that. So with your permission, if we could proceed to the case discussion and then take further questions, would that be all right?
Definitely. We are already late, I'm sorry.
We have some time. If we could share the slide, Shripriya. Thank you so much. The slides are visible. Dr. Shabnam, over to you.
Am I audible?
Yes, doctor, you're audible.
So good afternoon, good evening to all. Myself, Dr. Shabnam. I'm working currently as a senior resident in the Department of Radiation Oncology at IGMC Shimla. I will be presenting a case of 64-year-old male patient and with the diagnosis of CA right lung, non-small cell lung cancer, stage 4, presented with SVC syndrome. The presenting complaints were shortness of breath since 14 days, facial puffiness since 7 days, and blood in sputum, about 2 episodes in last 7 days. So patient was apparently well 14 days back when he developed shortness of breath, which was insidious in onset and gradually progressive from last 10 days. Patient had also complained of facial puffiness, which developed in last 7 days, and it is progressive and it was more during the morning hours. Patient also complained of 2 episodes of blood in sputum, which was about 1 to 2 teaspoon and in amount, and which was fresh and bright red in color. So on examination, patient was conscious, cooperative, and well-oriented to time, place, and person with Karnofsky performance status of 80. The facial puffiness and flushing of face was at present, and neck and the upper chest shows the dilated veins on examination. General physical examination were within normal limits, and the SpO2 was 95% in room air. The pulse rate is 104 per minute. Blood pressure is 124 by 86 millimeters of mercury. The respiratory rate was 21 per minute. And the respiratory system examination shows the breathing sounds were decreased in the right upper chest, whereas the CNS, CVS, and the per abdomen examination was within normal limits. So for investigation, the patient was undergo CECT thorax, which shows a large ill-defined heterogeneously enhancing mass of size of 5 into 4 into 3.4 centimeter with cavitation involving the suprahilar region in the superior and the basal anterior basal segments of right upper lobe. Along with this, there are hyperdense lesion present in the bilateral adrenals and multiple enlarged necrotic lymph nodes in pericardial and pretracheal regions. There was also a thrombus in the superior vena cava with narrowing of the brachiocephalic vein. The bronchoscopy suggested of infiltration in the lower end of trachea, carina, and the right main bronchus with 50% of occlusion, which was having tendency of bleeding with touch. So the biopsy was done, and which shows a squamous cell carcinoma. The blood investigation, including CHG, LFT, RFT, and the biochemistry profile, which was completely normal, and the MRI brain was done, which was normal. So the psychosocial aspects, the patient is 65-year-old farmer by occupation living in a joint family and including a 93-year-old father and 82-year-old mother and a 58-year-old wife and a 34-year-old son. The father is suffering from the COPD and has acute exacerbation, for which he has to very frequently admitted and he's on regular medication. The mother is suffering from dementia and has a tendency of getting lost. His wife is taking care of all the person in the families and the household. The son was a taxi driver in Gujarat, and he is unmarried, and he has to leave his private job for taking responsibility for the completion of his father's treatment. And the patient doesn't want to know about the disease. He doesn't want to know about the exact situation and the plan of the treatment or the prognosis, as it makes him more conscious and anxious. The patient is worried about his son, his marriage, and the expenses he need to bear for his medical treatment. But at the same time, he is thankful for the government is providing the free treatment, including diagnosis and the treatment, and also he will get a cancer pension also. But he is worried about his son and the family finances as he become unemployed at present. Son is worried about his father's condition and wants him symptom free as soon as possible. So the medications were given as the patient was immediately admitted as he appeared in the OPD with the symptoms, and the symptomatic treatment was started as the proper position, IV antibiotics, IV Lasix, nebulization with Budicort and fluticasone, oxygen inhalation. And after taking the biopsy, the patient was started on IV dexamethasone and further planned for hypofractionated radiotherapy, that is 25 gray in 10 fractions. Along with it, patient is also started in low molecular weight heparin, which was given at the dose of 1 milligram per kg BD dose. Next slide. So the main concerns were the shortness of breath, the facial puffiness, anxiety issues of the patient, and the financial issues for the family. So to summarize, the 64-year-old male patient of CA right lung, stage 4 squamous cell carcinoma, presented with the superior vena cava syndrome. So the discussion points, one is, does this patient need the palliative care? If yes, then when to start? The second is what all we can do for the patient's wife who's taking care of the old parents along with her husband. And third is, how can we help the family to deal with the financial issues? So thank you. That's all from my side.
Thank you, Dr. Shabnam, for that presentation of the case. Definitely a case having a lot of issues. So coming to your discussion point 1, what is your comment on that? Does this patient need palliative care? If so, what are the aspects which are the dimensions of palliative care which needs addressing in this patient?
Yeah, obviously this patient definitely needs the palliative care, and it should be started itself at the time of admission or at the time of patient and doctor interaction, at the time the communication aspect, and then further plan and such type of things to be discussed with the family also, and the prognosis and all the benefits versus risk ratio, all should be discussed with the patient itself and the family.
Right. Is this the first time the patient is getting a palliative care perspective during his treatment?
Yes. Patient is for the first time he's appearing in the OPD with the SVC syndrome.
Okay, so this is one place where we can see that. Imagine if you said that he is already being treated with radiotherapy. If at some point, at the point of diagnosis earlier on, if palliative care would have started, probably a lot of his socioeconomic issues could have started. We could have at least started addressing them or started making a plan as to how to address those issues, because we know that may become a problem later on. Whom all would you like to include in your team for addressing the issues for this patient?
The patient itself and his wife and his son, which was available, and all other, if the other attendants are also present at the time, we all should be seated and we should discuss about the whole things about the patient and concern about the social issues or issues about the treatment and the outcome of the treatment.
Right. Dr. Arnav, would you like to unmute yourself, please?
Yeah, so I think we are seeing this question in all the case presentations of, does this patient need palliative care? So, even my understanding was that there is a dichotomy. Up till one point, there is curative care, and then after that, when nothing works out, palliative care. But I think the last few sessions have really opened my eyes, and I'm very sure others' eyes as well, that palliative care doesn't start at the end of curative treatment. It starts from the first visit where we see the patient, and the goals of palliative care may change, but the idea of whole person care and palliation and making him comfortable, looking at all the biopsychosocial aspects, starts from the first visit, even before we have reached the end of curative treatment. So I think uh, that point was very clear to me, and I'm very sure to others also. So so that is a very good learning point for me in this few sessions, and hoping to learn more in the future. So yeah, thank you.
Thank you, Dr. Arnab, for that comment. Coming back to Dr. Shabnam, what I was asking you is, apart from the patient and the immediate caregivers, from your side, whom all would you like to be a part of your team to take care of the issues which the patient and his family is facing? So because we are always in a hospital setup,
yeah.
We always think in terms of treatment aspects. Now we have started eliciting what are the non-physical aspects or the non-physical dimensions which we look into deeply in palliative care. But to address them as a doctor may not always be possible. So your team always includes non-medical personnel as well. So that is what I meant by asking that. Whom else would you like to have in your team?
Yeah, I think the people closely associated with the family can help in this scenario. They can help wife off for 1 week, and other people can help with the deal with the staying in the hospital and take care of his husband. I think this will be give some rest to the wife also, because she's taking a lot care of his mother-in-law and father-in-law, who are also suffering from COPD and they're old. So I think the closely associated people with this family can help, I think.
Yes, definitely. They can use
or
as
NGOs,
much help as they can get.
NGOs or like the willing, some people are willing, like there are a group of people like after retirement or something like that. They can help these kind of patients also.
Yes, definitely, doctor. So we have started getting some responses on the chat as well. So definitely we need a social worker, who would have a network of these kind of people. One is a network of NGOs. Other is always, we have been seeing this over the past few sessions, the role of volunteers. How we are thinking about some amount of rehabilitation, as well as other issues which the family members are facing. So one thing is bringing them under the umbrella of medical care, and then ensuring that whatever care which we are given, there is a continuum of care which a doctor may not always be able to address or make happen. So a role of social worker, volunteers, definitely is required. So we have started receiving some. We have a question on the chat box. Dr. Shalini is asking, what is the distinction between care and palliative care? Is there one? If you care for symptoms in a cancer patient with a life-limiting illness, is that called palliative care? Jewell sir, would you like to take that question?
That necessarily is palliative care. So if we take a life, we have just kept that distinction of life-limiting disease, because otherwise all care would be palliative care. So in a life-limiting disease or a progressive disease, caring for patient symptoms, not only for the patient symptoms, for the family, during the patient's life and even after the patient's demise, all comes in the realm of palliative care. My understanding of palliative care, I'll just tell you. I mean, I don't know how many palliative care physicians would agree with me. If everyone had the time and the right attitude to care for all the symptoms, palliative care would not be necessary. If an oncologist, who better than an oncologist to take care of symptoms in an oncology patient? Who better than a cardiologist to take care of symptoms in a cardiology patient? I have no clue about cardiology, the different medicines in cardiology and all this. And I really get scared whenever a patient from cardiology is referred to me. So the only thing that palliative care physician provide is we dedicate some time for the symptoms and we probably give a different set of eyes to say, to give a different perspective and to act as patient advocate. So that's all it is. So we don't have any magic drug to treat anything else. And we obviously won't know as much about cancer as an oncologist, as much cardiology as an cardiologist. We are not like system related specialists, right? We just treat the symptoms as it is. Just lend our ears and eyes. That's
very true, sir. I do second that as well. I remember 2018 was my first encounter with palliative care, and my first impression was it's so unfortunate that we have a subject like palliative care, because this is something which should have been ingrained in every physician who is being trained. But later on, when I saw the practical side of it, the amount of time which we spend to explore issues, and with a country like India where the population burden is so much, how can we expect a physician to spend this much time and to make solutions for all these dimensions of health which is there? So definitely a distinction is needed between the usual healthcare and palliative care.
Exactly. The average, an oncologist in my institution sees around 35 to 40 patients a day minimum. So we can't expect them to. That's not humanly possible. So that's how a palliative care department become relevant. So as Dr. Deepak rightly said, it should be integration rather than segregation. But unfortunately, integration won't work within our constraints. So segregation is a necessity. That's all. It's not the ideal one, but it's merely a necessity.
Right, sir. So we don't have any more questions coming in. We have a couple of minutes for the session to end. If you have any closing remarks, sir. Dr. Jewell, if you can hear me. Sir, I think you're muted.
Yeah, sorry. Please tell me, Dr.
Yes, sir. So we just have a couple of minutes. I was saying if you would like to give your closing remark on palliative emergencies before we end the session.
Yeah, I mean, as I mentioned in the closing remarks, so the only thing I would like to mention is whichever thing that you come across in your clinical practice, which is actually causing severe distress to patient and decreasing the quality of life, please treat it as a malignancy and treat it as an emergency, and always ask the question of whether whatever you do is going to provide any meaningful benefit to the patient. That's all I would. Thank you for the opportunity, and it was really nice interacting with you all. Thank you so much.
Thank you so much, sir, for taking time out again out of your busy schedule towards the evening, closing up the day, to spend all this time. And the session which you took, really informative, including going through the pathophysiology of each situation, hand-holding us through the treatments. This is as elaborate and as comprehensive as it can get, as I had already mentioned. So thank you so much for that, sir. We're looking forward to have more sessions with you and more interactions from all the participants as well. So over to you, Shri Priya, for closing. All the participants, please remember that the session ends here, but if you have questions, the WhatsApp group is always open for discussion. Over to you, Shri Priya.
Thank you, Dr. Deepak. Dr. Jewell Joseph, thank you so much. As Dr. Deepak said, you joined us towards the end of the day, and an excellent session as expected, and we do look forward for more such sessions. And it gives me a personal pleasure that as a future beneficiary, as a future patient, I am seeing that the participants of this cohort are getting the ideas of palliative medicine as it is meant to be, and an assurance as a non-medical person that I will be getting what I require, what I need towards the end of my life, gives me a ray of hope. And believing that this ray of hope is being spread across everywhere where you all are into the field of medical treatment. This is Sri Priya, along with Dr. Jewell Joseph and Dr. Deepak Sudhakaran, signing off from the Tips Eco Hub for the day. See you in the next session. Till then, everyone, take care. Bye-bye.